Think about your brain like a muscle, right? If you're a strong, healthy person and you know you're going into a car wreck, you're going to withstand that car wreck very differently than someone going into it older and frail and sick. Same thing with dementia or cognitive problems. Alzheimer's disease may be developing in your brain. The symptoms might not be displayed for 5, 6, 8, 10 additional years because your muscle can just hold up better, like a dam that's holding it back.
Is this something that you can just get tested for at like your yearly wellness
Yeah.
exam regardless of age?
It's kind of like sometimes like asking for more information than you need right now.
So it's a test I should not take because I will worry about it my whole life. (1906). German physician Alois Alzheimer first discovers and describes the disease in the case of Auguste D., a patient with profound memory loss.
1915, the clock drawing test becomes the first cognitive test to objectively document cognitive decline.
1968. Researchers develop the first validated measurement scale for assessing cognitive and functional decline in older adults.
1984, researchers George Glenner and Kane Wong report identification of beta amyloid, the chief component of Alzheimer's brain plaques.
1986. Researchers discover that tau protein is a key component of tangles, the second pathological hallmark of Alzheimer's disease.
1993, the Food and Drug Administration approves Tacrin as the first drug specifically targeting Alzheimer's memory and thinking symptoms.
2023. Lecanemab receives approval from the FDA as a treatment of early Alzheimer's. Donanemab becomes the second treatment to receive approval from the FDA that addresses the underlying biology of Alzheimer's. And today we'll be discussing breakthroughs in the treatment of Alzheimer's disease. My name is Caitlin Heckel, the host of the Decoded podcast, where we break down recent innovations in healthcare with specialists from Ochsner Health. Today, our first guest is Dr. John Sawyer, and I will go ahead and let you introduce yourself.
Sure, I'm a neuropsychologist at Ochsner main campus on Jeff Highway in New Orleans. I co-direct the Center for Brain Health, which leads Alzheimer's and dementia-related kind of care programs for Ochsner Health in the state of Louisiana and then kind of around the region.
Great, thank you. We're so excited to have you on today to talk about Alzheimer's disease, dementia, and recent breakthroughs in the healthcare industry when it comes to potential treatments and diagnosis. Can you first start off by telling us what is Alzheimer's disease?
So Alzheimer's disease is a neurological condition, and what happens is that as people kind of age, their brains unfortunately can start to develop amyloid-related proteins. So these proteins start to build up in the brain. Think of this like almost like a chemical where your brain has too much of it and your brain can't clear it out. And then over many years, as that chemical starts to build up, it causes the cells in your brain to die off, the tissue to kind of die off. And then when that happens, it starts to pick up steam and start to die off in other areas. And that's where you start to have the cognitive symptoms, the memory loss. Usually starts in an area of the brain where memory, short-term memory is, and then it spreads from there. A lot of people will ask me, well, how is Alzheimer's disease different than just dementia in general? And I like to kind of think about dementia and tell people dementia is like an umbrella term in the same way that we think about cancer. So there are many different types of cancer, right? You have lung cancer, ovarian cancer, breast cancer. The same thing for dementia.
Dementia is like the umbrella, and then Alzheimer's is underneath, correct?
Correct, yeah. And think about Alzheimer's is occupying half of the umbrella, basically.
Okay.
So dementia just means two things, just two simple things. So one is you're having more trouble with thinking and memory than we would expect for your age. So we can't just chalk it up to getting to be 65 or 70 and, going through all the names of the family members before you get to the right one.
Right.
Yeah, if that were the case, my mother-in-law would have it. But it's measurable cognitive decline more than we'd expect for age. And then the second piece is that not only is it cognitive change or decline, you also have more trouble kind of managing things in life that you normally could manage for yourself. And I don't want people to think about like, okay, you're unable to like care for yourself, like bathe. I would want you to think about it even more complexly than that. So like forgetting to take medications more than normal, potentially kind of like not paying bills as reliably, kind of making some bad decisions. So it starts off really mild. Usually when people think about it, I like to ask them, let's say your wife or daughter or son just were disappeared. Do you think you could exist in the world completely by yourself? And we would expect most people who are adults to be able to do that. If they can't, then you kind of know, okay, they're having some cognitive trouble and they need someone kind of looking over them. And then dementia is on a spectrum or severity, like almost any disorder. And so we have mild, kind of moderate, and advanced. And so when many people think about dementia, they immediately think nursing home, right? They think at the end stage. And I want people to think about dementia really along a spectrum, and people move through it when it's progressive. Unfortunately, most people kind of don't get assessed or treated early enough. For most people in the mild stages, family members kind of think this is normal for age, or they don't want to bring it up. And then what usually happens in 80% or more of the cases where people come in to treatment is the wheels have fallen off at a certain point where we just can't say this is just dad being, not listening to mom kind of thing. And so that's really where a lot of people come in for treatment. The unfortunate reality, though, around dementia is the earlier you get it, the more likely you are to, benefit from these more recent advancements, which I'm sure we'll talk about at some point. And so that's why it's really important for people to think about dementia as not just at the end stage, but instead, like dementia runs through a cycle, or runs through a progression from mild to advanced.
Okay. I have so many questions.
Yeah.
First, you mentioned the earlier that you get dementia, the more likely you are to benefit from new treatments. I have seen recently some cases where younger people, like in their 40s, are like they're getting dementia or they're developing dementia. Why? I mean, why? Why does that happen? And what are there any type of signs to look out for in a younger person as opposed to an older person?
Yeah. So a couple of things. So one is it's not so much the earlier you get dementia, but the earlier you catch it, the earlier you diagnose it.
Got it. Okay.
Once someone gets to the moderate stage of dementia, we think about it like a house that's on fire. At some point, the fire has just engulfed the home, and there's nothing we're going to do that's going to put it out, right? And so the same thing with these new treatments. The new treatments will not benefit people who are in the moderate stage of dementia or later. That's why you want to get there as early as you possibly can. Now, for early onsets, when we think about when dementia starts in general, 90 to 95% of cases start after the age of 65. And then really the vast majority of them happen after 75. And so it's only 5 or 10% of cases are before 65.
Okay.
And once we get into mid 50s, late 40s, it is rare. So the first thing I want people listening is that it's rare. And I have this rule of thumb that I tell lots of people. It's not a rule of thumb that is 100% accurate, so I'm going to be really clear about that. But the joke is, like, if you think you have it, you likely don't, right?
Okay.
Because most people walking around with Alzheimer's dementia aren't raising their hand and saying, hey, I think I have dementia.
Right.
That just is not the case for most patients. Now, not all, of course. And so if you're young and think you have dementia developing, it's very unlikely that that's the case. And much more likely something else going on. There are a lot of reasons why we have cognitive symptoms before 65. And the most common reasons are things like depression, untreated hearing loss, sleep, not sleeping really well. Another kind of factor, we're here to talk about Alzheimer's dementia, but a quarter of all dementias, so almost 25% of every person walking around with dementia has what's called vascular dementia, meaning dementia from poorly treated diabetes, high blood pressure, high cholesterol, sleep apnea. So we think about, and so if you think about this, remember the brain is an organ and needs blood, right? In the same way that the pancreas needs blood and the liver needs blood. Well, the brain's not getting a good quality blood flow for 10, 20, 30 years because of blood sugar changes, blood pressure changes, oxygen limitations at night. That organ is going to be impacted. And then pretty soon you're going to have cognitive problems, not necessarily related to a disease process called Alzheimer's, but instead from these uncontrolled heart and blood vessel conditions as we get older.
Okay.
And so that's why I like to think about really brain health starting as early as possible, because a lot of people can get dementia unrelated to Alzheimer's disease.
Okay. So then essentially brain health is tied to overall health and wellness.
Exactly. And we
Okay.
think about your brain like your heart, and you want to keep it as healthy as possible, like all those things together.
Okay. I want to ask before we get to how exactly Alzheimer's is diagnosed, how would a loved one approach a family member who they think might be struggling with dementia?
Yeah, that's my everyday.
Okay.
So it is, first off, every person is different. And so every strategy is going to be unique to the person. I'm not going to say, if you say these magic words and click your heels, they're going to go to the doctor. I tend to think of it like this. First, if you're noticing symptoms, why most people don't want, as a caregiver, why most caregivers don't want to bring their loved one is that when they say the word memory trouble, everyone thinks dementia, the person's crazy and incompetent, and they go all the way down the rabbit hole, right? I would want you to think, oh, like any other condition, more than likely it's not something catastrophic, right? It could be that you have a vitamin deficiency, or that you're not sleeping well, or that you have some other irregularity. Let's go figure out what it is. We don't even know if it's that. It's also possible that you're noticing something and it actually is really normal for age. So just get it evaluated.
Okay.
That's the first tact. Like, we're not saying it's dementia. We're just saying, hey, we think you have thinking trouble and it could be sleep apnea. Well, let's get that treated. Does that make sense?
It does make sense, yeah.
If someone's really resistant to that, which is common, I think it's also okay to say, well, Medicare requires this every year. And they do. It's called the annual wellness visit, and it requires a cognitive screening. So it's something that you have to do. It's not because you're noticing symptoms. It's just a requirement. So you're not technically lying about it. And then the third is that if someone doesn't go or won't go, it's important to recognize that when someone has cognitive trouble, if they have their checkbook and we're going to write a check and give all their money away right now, you probably would not say, okay, well, they want to do that. Does that make sense? You would just say, no, it's not happening. So it's like, get in the car, let's go, we're going. I don't care what you want. Does that make sense? Because at some point, the good decision making has to kind of prevail. So there's usually, I would say, a relative, a family member that is a lot more motivating to that person, and I want that person to take them to the doctor's visit. It's always the spouse or the very highly functional daughter who does everything for the family that gets the wrath. So then don't have her do it. Get the brother who doesn't do anything anyway to pick up dad and take him to the doctor. Does that make sense?
Yes.
And then, so it's important to think about, how do I motivate this person to go as well?
Okay. That it totally tracks, and I'm already thinking of the people in my family. I'm like, it'd be this one, like that would be driving.
Absolutely,
grandma
someone to
or
go.
something.
Yeah. Grandma's like, okay, fine, I'll go. The grandchild's
Fine.
here.
If we can go out for lunch after, I guess I'll go
for sure.
get my brain evaluated.
Right.
So then, how is Alzheimer's diagnosed? Let's move into that.
So we think about an on-ramp to diagnosis and then an off-ramp to treatment. And there are many on-ramps to diagnosis, but the main part of this is someone having more cognitive trouble than we would expect for their age. And the way we generally measure this is that we have them take a test like any other test. And those tests are graded based on age. And we know that the average 70-year-old does this. The average 80-year-old scores this. And so the clock drawing test was developed over a century ago and is still really one of the most helpful tests because almost everyone learns. Even I have a 9-year-old and a 7-year-old. They still learn to draw a clock. And it's a very well kind of worn skill. But it's also a skill that I'm not walking around drawing clocks every day right? And so when you're asked to do it, it's a novel thing in the moment. But most people can do it if they had to do it. But when you start to notice, someone's having trouble drawing a clock, it is a very sensitive indicator that something is going on. Like someone should be able to do this. We also think about other cognitive tests, so like tests of memory. When we think about Alzheimer's disease, for instance, memory is generally the first symptom that's noticed. Interestingly, though, when we measure brain function, the next cognitive skill that kind of follows it traditionally in Alzheimer's disease is generating words according to a category. So like if I say, hey, Caitlin, I want you to call out as many animals as you can think of in 60 seconds. You're going to have more trouble with that if you have Alzheimer's disease than if I said, hey, I want you to generate as many words you can think of that start with the letter F. There's also brain imaging. So there's PET scans that look at certain markers related to Alzheimer's disease, certain lab tests that look at markers related to Alzheimer's disease. And then, of course, what the family and the patient say about how their symptoms started. So if it started rapidly overnight, it's not Alzheimer's disease. If it's something that started slow and kind of progressively got worse, that's more consistent with that. So it's almost like, you're putting a lot of clinical data in different buckets. And at the end of the day, your job is to see which bucket has the most data. If there's not a signature like, if your blood sugar is at this level, you have type 2 diabetes yet. So
Okay. What is a marker related to Alzheimer's disease?
it's a great question. One is amyloid protein. So I had mentioned earlier when amyloid builds up in the brain, we think of it like a toxic chemical that just does not get out of the brain. And so now we have either a blood test or a cerebrospinal fluid test. I mean, like a lumbar puncture to see, do you have an abnormal buildup of amyloid in your system? Now, the problem, of course, is that a lot of people have it that do not have cognitive symptoms or dementia. So there's a challenge in kind of figuring out, well, who's going to later develop dementia despite having this protein? Because there are lots of people walking around with amyloid buildup that don't have cognitive symptoms.
Got it.
So you kind of traditionally have had to have cognitive trouble and a positive amyloid test for us to get to Alzheimer's disease.
Okay.
But there's been new research that shows that even when you follow people who are cognitively unimpaired, at some point they will develop dementia. It may be that they just have died before they've developed dementia. It may be that treating people who are cognitively unimpaired but have amyloid positivity may make sense. The science is still out on that.
Okay.
But part of the issue around cognitive impairment, this is going to get hyper complex for listeners, but I want people to think about it like this. Dementia starts sooner or later, oftentimes relative to your cognitive abilities as well. So think about your brain like a muscle, right? And so if you're a strong, healthy person and you're going into a car wreck, you're going to withstand that car wreck very differently than someone going into it older and frail and sick, right? Same thing with dementia or cognitive problems. And so Alzheimer's disease may be developing in your brain, but if you're very smart, if you've had a very cognitively stimulating job, for instance, or a lot of education, you may not notice, or the symptoms might not be displayed for 5, 6, 8, 10 additional years because your muscle can just hold up better, like a dam that's holding it back. And so that is why it makes detecting Alzheimer's disease related to cognitive impairment a challenge sometimes, is that people's abilities are different and they vary based on a lot of factors.
Right.
And so this is why we're excited about blood tests and imaging markers, because it at least it helps us to remove some of the variability related to humans differing in their cognitive abilities.
Yeah, that was a great visual with like holding the dam back, and it just is motivating me to just keep my brain sharp, honestly.
Yeah,
like just keep engaging my brain. When you mentioned having positive markers, what was the word again? What was the...
So amyloid,
yes.
and then and tau. And so we think of those as like amyloid starts first, and then tau kind of happens a little bit later.
Okay.
And amyloid is like the chemical that builds up, and tau is like the thing that causes the house to fall down.
Okay.
And if you look at the most recently approved drug,
I forget the name of them already. They're so...
Lecanemab and
Yes.
Donanemab. Yeah, you have to say it over and over again in the mirror, and then you get it. So.
Right, 3 times, and then it appears. How do they work?
Those drugs are designed to remove amyloid from the brain. They do a really good job of removing those amyloid proteins from the brain. So they're not building up anymore because it takes them out.
Can anyone just go get a test for this, or do you have to... Because now I'm like, oh gosh, if someone doesn't have or if someone does have Alzheimer's in their family, is this something that you can just get tested for at like your yearly wellness
Yeah.
exam regardless of age?
It's kind of like sometimes like asking for more information than you need right now.
So it's a test I should not take because I will worry about it
Well,
my whole life.
yeah, and it's we don't kind of know what's going to happen. We have no idea if the infusions would even make sense.
Okay.
That's a whole other decision clinically. That's not even, it's certainly on the horizon, and researchers and other physicians are talking about that. It's just not there right now. And it's not determinative. So some neurologic disorders like Huntington's disease, for instance, like if you have the genetic marker, like you're going to get it. Like that just is what it is. That's not the case with the amyloid tests right now.
Okay.
And so the likelihood of knowing about it now and how it impacts how people frame it and think about it, in my experience, generates more anxiety than it needs to.
Yeah. Like,
And
that makes sense.
yeah. And so most people, once you get past 65, Alzheimer's disease and dementia is generally more related to the effect of aging than it is family genes. And everything in life is a mix of genes and environment, right? That's just kind of what we understand. But Alzheimer's disease that develops earlier tends to be more genetically linked. When it's later, it tends to be more as a consequence of our brain just getting older, and we naturally are more susceptible to other conditions. Once you get to be 80 or 85, 40% of people walking around already have, Alzheimer's disease developing in their brain. So then the question is, knowing it at 30, what does that mean right now? If that makes sense.
That does. So what happens after someone is diagnosed with Alzheimer's?
Yeah, so it's changed, I would say, drastically in the last 12 months. Never in all of human history has there been something that we could meaningfully change the course of Alzheimer's disease until now. So if I was going to get it, this would be the year to get it. For patients in the moderate stage or more, which is the vast majority, generally speaking, we've kind of innovated around care management. You want to think about we did several kind of, Caitlin, some focus groups, and the old way you think about diagnosing dementia are really a lot of there's nothing to do disorders. So you come see a specialist like me, we'd give you a diagnosis, and we'd say, good luck, basically. You know what it is, and here's a website to read about it, which is like really crappy, right? And so we wanted to create, how can we manage and help patients and families navigate this awful thing over the next 10 to 15 years, because it's not a disease that ends in a month. And so we created an innovative care management program where we adapted a model that was developed at University of California, San Francisco, by Dr. Pacine and her colleagues, called Care Ecosystem.
Okay.
And the goal of this program is to do kind of four things. So one is to have a consistent home base for your dementia care. Most people are like, who do I call and what happens and where do I go? And if you've ever called a health system's main number and you've gone round and round and round before, right?
Yes.
You don't want that. The second is that we want patients to have better quality of life and to be better cared for in the home. And so we have our care navigators coach their caregivers about what to do and what not to do. Caregiver kind of burnout and well-being are huge. There's a massive amount of life stress that is imposed upon either spouses, adult children, and caring for their loved ones. So how can we alleviate that for them? And then also kind of reduce a lot of unnecessary utilization of either health expenses. So like going to the ER when it's not needed, or the hospital, or going to the nursing home. That's kind of the design of the program. And we've had a lot of really good success and kind of feature around doing that and showing. And so that's really kind of how we think about care, is both like making diagnosis happen earlier so they can potentially be funneled into a treatment pathway. Or if not, then we want them at least to be in a care pathway where they can get enough support to really improve quality of life, reduce time to their nursing home, and things like that.
That's great to hear, because I had questions about loved ones and how do you even, first of all, hear about a diagnosis or accept a diagnosis or learn to care for someone that you love who is diagnosed with Alzheimer's or, something of that nature. So I love hearing that.
You want to think about, how do we improve someone's trajectory, even non-medically? And so some of that would be like diet, exercise, kind of cognitive activity. And so those are things that you would want to be helping your loved one do. So the number one thing I tend to recommend, because it's the thing that people are most open to doing, is physical activity. When we look at people like 4 years after a diagnosis, if they're physically active, they typically are better. Most people in New Orleans are not going to change their diet meaningfully. It just
give up fried
it
food.
is what it is. But increasingly, having more Mediterranean style foods is good for your brain. I think anyone listening who's like, how do I do that? Just go buy a cookbook from Amazon that your youth are actually going to use and just have fun making the recipes rather than like, don't run into your pantry and start throwing everything out and saying we're only having almonds and yogurt the rest of our life, but instead,
olives only.
yeah. And then finally, staying as stimulated as possible.
Okay.
Those are the things. Now, what I don't want people to do, what happens with caregivers is that if dad has dementia and mom's like, you got to play cards all the time, it's like, well, no, that's like missing one card game is not going to do it, And so that's when caregivers kind of go nuts. Is right.
It's not funny, but it is.
No, it's so true. It's very, very true. Because they
Yeah.
think if I don't push them, they're going to lose it.
Right, like Sudoku 24/7.
24/7, right. And so there is no cognitive game that's better or worse. It's just whatever you're going to actually do is what I would prefer. So don't go spending money on, a bunch of apps for your brain or supplements. That's all just a bunch of
Just
quackery.
go on a nice walk.
Yeah. I would, exercise, get actually decent food.
Do a crossword
Puzzle for sure. Yeah. Talk to people.
Talk to people. Yeah.
Have a conversation.
Yes.
All those things are going to keep your brain really active.
Okay.
So that's what we do. The other is with care management. It's really about, for the caregiver, remember, as someone changes, you're having to relearn how to interact with that person. And what happens for most caregivers is they know how to interact with them based on their relationship for 20, 30, 50 years. And they have to constantly inhibit how they have interacted with them for how they need to now. So an example is, well, I told you to do that and you didn't do it. That happens all the time. Well, they're literally not going to remember. That's just the like actual thing of the disease. And so you getting upset is normal, but unlikely to make them remember it.
Right.
And so learning new strategies to interact are really important. When many patients with dementia will get agitated or upset, and then loved ones will try to argue with them about why they're wrong. That doesn't work with me, and I don't have dementia.
I was just thinking, like, I would not want that.
Right? So just change the subject. There's no need to get into it. Now, that feels dismissive in most normal adult conversations. Like if you said, hey, I have something I want to talk to you about, and I said, hey, what's the weather like today? You would think, oh, this has no interest in, very rude, right? But with someone with dementia, the issue is that you're keeping it in their short-term memory by talking about it. And you're aggravating them and you in the process. So just change the subject completely. Or you may need to get at a physical view so that way they have 5 to 10 minutes to reset. And then we're going to start right back at it.
Okay.
The other thing that caregivers have to struggle with is balancing autonomy and like safety. It's a really hard dynamic, right? Which is I want to let dad drive, but I don't want dad to kill him or someone else. And how do we negotiate that? And I always like to say, when it's related to issues that are critical, like safety, money, health, things that are like foundational to having a stable life, the person without dementia's judgment's going to have to trump, even if it's uncomfortable. And it's important for family members to really buckle down in those conversations and tolerate the negative feelings they get by setting that limit. Because the person with dementia at some point is going to go along with it. There are many that it's a fight and it is difficult. But would you rather dad drive and get in a car accident and right?
Yeah.
Or are we going to deal with the argument? And so that's why we coach and work with caregivers a lot around. We have to bite the bullet sometimes and say, okay, no driving, or nope, you're not paying your own bills anymore because we can't give $10,000 to imaginary people in some foreign land.
What are your thoughts on a caregiver? So if, let's say, their mother has Alzheimer's and she thinks that her daughter is her mom.
Yeah.
What are your thoughts on the caregiver just going with that narrative?
Yeah, I think it absolutely, for me, whatever works is the most important thing. If your mom thinks you're their mom or their spouse, and going along with it makes it easier, that's great. Sometimes it doesn't. Like so what may happen is like mom thinks, grandson is spouse, right? Well, we can't have her interacting with him, right, as spouse.
Yeah.
And so sometimes we can't do that, but it will depend on like what the situation is, right? So let's say mom has advanced dementia and she's just like adamant that she's going to manage her own money, but she's mismanaging it. Well, you may have to like take that decision away from her. And it's not because you just really want to upset her, right? It's that she's going to need a lot more care that's going to be really expensive. And we don't want someone to take advantage of her. Does that make sense?
Yes, it does.
And so doing those things to protect them is what's more important than interacting with them in a hopeful way that they're going to get better, because they won't.
Okay. I'm wondering, are there support groups that people can join, or is there, if you could give us resources, we could share that. Like in
so
the
our
caption
our care management program, that's probably been the thing that we are most proud of, is that we have both a support program. And so Medicare now just recently, so there's been another breakthrough in Alzheimer's disease, and that's that Medicare will finally cover our care management services.
Oh, that's great.
And so if you want to, you can enroll in our care management program. You will get a social worker that will meet with you once a month. We have support groups, education groups. We send someone to your house to do a home evaluation depending on where you live. So there's a lot of that, which is really, really nice compared to what we did 8 years ago even. So
Yeah, so it seems that the medicine's getting better, the support services are continuing to improve, and it seems like it's an uphill trajectory.
I mean, I've never been more hopeful in my entire life.
Good.
Just for people, I really want to make this an important point. When I had a patient of mine who I was giving her and her daughter the diagnosis. So the patient, the diagnosis, and her daughter was there. And the patient looked at me and she said, Dr. Sawyer, I don't quite understand what you're saying right now. All I know is it feels like a bomb went off in my body right now. That's all I know. Yeah. And that is what we're dealing with, right? We have a condition that fundamentally changes a person's personality and their abilities. It is the most feared condition as you get older, right there with cancer. And it is emotional to see people, patients of mine, over years decline, and what it does to them and their family members. It's just not fair. And so I am really gratified that hopefully the science will continue to keep up a lot of pace, and we can meaningfully treat this in a way that just is not providing a lot of support, but also like ending it finally.
Yeah, I hope so too.
All right.
Thank you so much for your time, Dr. Sawyer.
Yeah, absolutely. It's great to be here.
Thanks. And thank you for joining us on Decoded. We'll see you next time.